G'day, Kieran. Welcome to World's Best Physio.
G'day, Sam. Great to be speaking with you, mate.
Likewise, I did confess to Kieran before we started recording that I had a sense of awe, slightly starstruck, because Kieran is what's called a specialist physiotherapist, and you don't meet many of them. So, Kieran, if you could tell us a little bit about yourself and including in that, what does it mean to be a specialist physio?
Well, it depends how far you want to go back, but a little bit about me is I am actually a New Zealander by birth, and then I moved to Australia in the mid 1990s when I was in high school. And then I completed my physiotherapy degree here in Perth, Western Australia. Did my master's degree at Curtin University, and then I did my postmaster's doctorate fellowship at the Australian College of Physiotherapists, and am now a titled specialist physiotherapist. And my special interest is in non-surgical management of pain and injury across the body. And so that's something I do every day. And in fact, I just got back from teaching a shoulder workshop here locally in Perth. And so similar principles apply whenever you're looking at someone as an independent specialist offering non-surgical opinion. And so I like to teach physios about that kind of stuff and also offer it directly to patients. So that's a large part of what I do.
One of the reasons I'm so excited to have you on today, Kieran, is that you're a great example of the diverse career pathways that a physiotherapist can choose from. A lot of physios out there work in private practice, some work in hospitals, and they might have the expectation that they can either treat clients or they can own a clinic, and that's really the two options available to them. But you're a mentor to physios. You run more clients from your home through video consultations than you do in the clinic, even though you're still 1 day a week in the clinic. And you're also mentoring trainee specialists as well. Are there any other strings to the bow that I haven't highlighted?
Look, so really, the catch cry of my company is it's Global Specialist Physio. We run professional development, formal mentoring, and we give second opinions. So the other part, which you didn't cover there, is education. So I'll do actual workshops or lectures or seminars, but again, both online or in person. And for me personally, I quite like the diverse mix. Like I do enjoy working from home. It's pretty sweet. But I also like getting back into the clinic and seeing patients in person. And I also like teaching in person. So I kind of like the hybrid approach. Yeah, it's been pretty, especially since COVID. It's I've moved from primarily, I used to do a lot more driving around Perth, giving workshops and lectures and even second opinions at other clinics in person. I still do that, but it's a lot of it. More of it is via online video link.
And
Yeah.
from my point of view, the video consults is not just about yeah, I suppose a better work-life balance, a better convenience of not having to, yeah, risk having lower back pain from spending too many hours in the car. But it's also, I believe it's made me a better physio because I have
Okay.
to be more precise with my words and with my
Okay.
instructions, and I have to then teach the person that I'm helping how to palpate their own knee, for example, and then give me
Yeah.
the feedback that I need from that palpation assessment if I can't put my hands on them directly. And likewise, I think the face-to-face physiotherapy has made me better at telehealth. So, yeah, what do you see as the main advantage of having such a diverse skill set, education, mentoring, and consulting?
Well, like obviously when you do the 2 year program to become a specialist physio, a lot of the emphasis is on those elements. So you're getting formally mentored, uh, you're providing workshops and giving presentations, and you're getting
Mm,
feedback on that. You're also giving second opinions. So I think it obviously keeps it fresh, and
mm,
it makes you become up to date with what all the latest papers say, and you're part of disseminating that to the latest, emerging leaders and expert physios as well.
mm.
So I like that side of it. Um, And I think yeah, to me, I just feel like I'm always moving and traveling, and
Mm.
I definitely don't get bored. So that's probably
It would keep it fresh and interesting, that's for sure. And
yeah,
yeah, for the context of those watching or listening to this conversation, there are a smidge over 200 specialists in Australia out of 40,000 Australian physiotherapists. So it's a rare air that Kieran breathes, and he's a humble man, like every other specialist that I've met. Funny enough, it seems like the more skilled you become, the more humble you also become, which has been wonderful to see in the profession. So, Kieran, can I steer us down the direction of non-surgical rehab? Something that
yeah,
you mentioned you're particularly interested in. Um,
yeah.
why have you developed, or how have you developed this passion for non-surgical rehab?
Like that's a really good question. I probably pretty early on, actually, it was in the latter part of my undergraduate training. It was in my fourth year. One of the practices that I was doing some work experience through, they asked me to create a flyer, and it was on physiotherapy to treat hip arthritis and knee arthritis. And this is granted, this is like the early 2000s, right?
Way before
And
Glad.
so way before GLAD. And so I was looking into the research even then. And back then it was showing sort of equivocal outcomes in terms of
Mm,
patients having there's a group of patients who do very well with physiotherapy.
mm,
And so when I read that, and then I guess it was a part of like helping this particular practice owner
mm,
broadcast that, I think that just made me realize, hey, we're not just like offering substandard care. For
mm,
many patients, we're actually offering best care.
mhm,
And it might, for some people might think that surgery would always be superior or be a more sophisticated because it's using modern technology, it's using
mm,
instruments,
mm,
um, but then when you start looking at the studies, not just in physiotherapy, but when physiotherapy is compared to surgery,
mm,
you actually see very similar outcomes across the body.
mm,
And so I found that that hip and knee arthritis was a good place to start.
mm,
But since then, I've probably take a very similar look in the entire body, where we're thinking there's patients who have neck pain and maybe neck arm pain that can be managed with physiotherapy.
mm,
Same with shoulder, same with low back, same with hip, same with knee, elbow, some elbow pathologies, ankle sprains, this kind of stuff.
mm,
So, and then my special interest is knee, but even though I talk a lot about knee and ACL and meniscal management, I actually do non-surgical across the entire body.
mm,
And so I think the one of the hardest things I find is getting the physiotherapists to believe in their own treatment,
mm,
because sometimes the patients may be unsure if they're off to see a surgeon or if they're even booked in for surgery,
mm,
and they haven't explored physio yet. They haven't tried different exercises. They haven't
mm,
committed to a period of rehab to
mm,
even see if their pain can get better. I like being a part of, yes, facilitating that, but also training physiotherapists to
mm,
be confident and comfortable to deliver that to patients. That's
mm.
very much something I like to do.
So the
Yeah.
physiotherapist's lack of faith in either their own service
Yep.
or the physio's lack of faith in that person's prognosis or that person's potential to improve
Yeah. Yeah.
is a limiting factor on that patient or that client's recovery.
I often see that. And obviously I'm privileged because I'm doing second opinions. So
Mm, yeah.
the patients may have often already seen a physio who has done, say, 6 weeks or 12 weeks of programming. And I mean, there's different, depends on the case presentation, right? But some patients, the physiotherapy is actually excellent, but it just needs more time.
Hmm.
Sometimes we need to actually totally flip it
Yeah.
and we need to try something brand new.
Hmm.
And then sometimes I think we're wasting our time and the patient actually needs to go for surgery. So it's
Right.
that it really depends on the presentation. But I like helping the physios to be confident whichever path the patients need.
Mm. Mm.
Yeah.
Yeah, that confidence is huge, and a personal experience that I had that built my confidence on the non-surgical rehab of ACL and meniscus injuries was a Facebook group that I have to plug because it's been a great joy. I've only come into the group within this last month. I'm gonna botch the name, but it's something like ACL and meniscus recovery without surgery.
That's right. Yeah.
And it's got close to 30,000 members all over the world.
It's
And
got 36,000 members. Yeah.
I undershot it, I'm sorry. I was too nervous to exaggerate. So 36,000 members, and it's getting 10 posts a day.
Yeah. Yeah.
And
Yeah.
it's just filled chock a block with these good news
Yeah.
stories of
Yes.
people
Yeah.
saying, I recovered naturally
Yes.
from my full ACL tear. I recovered naturally from
Yes.
my ACL plus meniscus tear. I recovered
Yes.
fully from my ACL plus meniscus plus MCL. And
Yes.
and I'm looking at this thinking, I always hoped it was possible. I always believed
Yeah.
that the human body was capable
Yeah.
of healing itself because it's a master of healing.
Yeah.
But hearing these stories and these testimonials
Yeah.
has really it's actually got me to the point now where if you presented me with a case of an ACL injury, I would
Yeah.
be like 95% confident that I could walk them through what they
Yeah.
need to do to get back to their goals
Yeah.
without surgery. And like the trickiest part is most of the patients that I've had have already made up their mind that they want surgery before they come to see me.
Yeah. Yeah. Hmm.
So hopefully this gets out there. And I think you're right to emphasize the knees when you're doing your online stuff because it's especially in Australia, it's it's the headline. Like it's the ACL
Mm.
is the one that writes the front page of the newspaper. Tennis elbow
Yeah.
doesn't really
No.
attract the same hype. Um, Even though the return on physiotherapy investment for tennis elbow is arguably higher than for arthritis and for chronic neck pain, according to one report at least. Um, so I'm going to shut up and let you talk about the BLEX protocol, which is different to the cross brace protocol
Yes.
for
Yes.
rehabilitating ACLs. And I'd love you to
Yeah.
highlight, Kieran, what is the difference between the BLEX protocol and the cross brace
Yeah.
protocol, both in terms of um, the patient experience,
Yeah.
risks of adverse events, and the outcomes.
Yeah. Well, look, probably just taking a step back, there's the listeners may not know if you're a patient or if you're a clinician that there's always been, even though the narrative around ACL injuries is that surgery is a must or surgery is necessary or surgery is the best treatment. There's been research performed since the 1980s that's shown very similar outcomes again if you're just doing a rehabilitation program. So this is not considering a bracing program or a bracing protocol, that there's groups of patients who do very well, in fact, just as well as surgery
Mm,
with an exercise program without surgery.
mm,
And so I came across that research in detail probably about 10 years ago, just over 10 years ago.
right.
I'd always had an inkling that there'd be patients who could be managed without surgery, but I just hadn't really done a deep dive into it.
Mm,
Uh, and I've shared my story in different blog posts and in articles for online education platforms. But basically, there was two patients I had. One who had multiple surgeries, 5 surgeries, uh, that she kept re-injuring her knee. And then
mm.
I had another patient who just refused to have surgery. So you said that there's a group of patients who are committed to surgery when you first meet them, and I would
Mm,
say that's true. But then you see some patients who are the polar opposite,
mhm,
and they're like, surgery's my last option.
mm,
And so I'd never encountered that before prior to around 10 years ago.
Mm,
And this patient said to me, look, I just don't want surgery. My friends have had it, it didn't work, their knee
mm,
re-injured.
mm,
And so I took her through a course of management,
mhm.
and she ultimately returned to field hockey in 4 months. And she was an A grade amateur. And I never did a repeat MRI with her. But
Why
she
would
just
you?
functionally, well, I just went on function. So I just
There's
went
no
based
argument
on,
to do the MRI. It's a waste of money, isn't it?
well, this is where it gets a bit more, we can tease the topic out more. Maybe we haven't got enough time for this podcast, but in a lot of the COPA versus non-COPA studies,
Mm,
they never actually did a follow-up MRI.
mm,
And in some jurisdictions, like in the Netherlands, they don't, they actually don't do an early MRI. They just go based on the patient mechanism and an X-ray. So if you clear the X-ray for a fracture
mhm,
and the patient's had a giving way, then felt the pop, then had a hemarthrosis or swelling in the knee,
mhm.
and they
Are
they
they
just
doing
assume that you've
are they doing
they
ligament
just
testing as well?
they can you can do a ligament test to confirm that the ACL's lax,
Hmm.
and the patient has got an ACL injury.
Hmm.
They don't then do an automatic early MRI. They only
Mm.
do a follow-up MRI if the patients are struggling and continuing to struggle.
Do we do a lot of MRIs in Australia compared to other countries?
Yeah, yeah, we
Yeah.
do. And we pay
I
for that as taxpayers.
right. And the ACL surgeries.
Yeah.
Yeah.
So so getting back to your question, right? So
Mm,
like how does so what is BLEX and how is that different to CROSS? So BLEX is a part of a research study that is yet to be published, but we are recruiting patients in the Australian sector as a part of the Australian knee injury study. So we're doing a sub study of that larger study,
mhm,
and we're looking at the effect of, in fact, in person versus telehealth for managing non ACL injuries and meniscus injuries.
mhm,
And it's a physiotherapist led protocol,
mhm,
which basically means they see someone who is experienced and trained in non surgical ACL management.
mhm,
We put the patients into a brace that stops them straightening their knee, but they can weight bear.
mhm,
And then we take them through a series of exercises, and then we kind of wean them off the brace. And then in their case, because they're a part of the study, we do a follow-up MRI.
mhm,
And then we see if their ACL has indeed healed or not.
mhm,
And so that's quite different to cross brace, which is a protocol where the patients have to bend their knee up to 90, they have to fulfill a certain criteria. They have to bend their knee up to 90 degrees.
mhm,
They have to see a physician, a medical doctor who has to put them on blood thinners
mhm.
because the risk of a blood clot is much higher than if you're having your foot weight bearing through the ground.
So it's a
And
non-weight
then,
bearing 90-degree bracing.
yeah,
So
yeah,
there's immobility, reduced blood flow,
yeah,
pooling in the lower leg, and
yeah,
okay. Yep.
yeah. So like we came up with BLEX based on a collection of studies that have already existed. So
Hmm.
we just built upon that.
Hmm.
Um, there's been studies from actually the mid 1990s
Mm.
that show confirm that because the old idea was that ACL tears never healed, and that if
Yeah.
you actually trace that back, it came out of this animal study from the 1960s where
Okay.
they severed dogs' ACLs
Yep.
and then went back in and opened them up actually
Yep.
and looked at the dog's knees, and there was none of the ACLs had reattached, and there was more arthrosis, like more arthritis in the dog's knees.
So is that where
The
the whole
the
idea that if you don't have an ACL, you're more likely to have
yeah,
arthritis came from?
this is where it spawned from.
Ah.
The issue is, and like the glaring issue when you look at it with, 20, they say 20, hindsight's 2020,
Hmm.
because they didn't put the dog into a brace, and obviously
Mhm.
they didn't do a rehabilitation protocol with the dog.
And
So,
if you've got a weak and sore knee, you're going
yeah,
to offload it. That
yeah,
offloaded knee is going to get weak. and
Yeah.
arthrosis is going to develop because of that weakness.
Yeah. So what this Japanese surgeon did, Ihara, it was in 1994, and they did some follow-up studies shortly after. They had it's called a double arthroscopy or a second look arthroscopy.
Mm,
So you can look it up. It's in PubMed. They went in, confirmed that there was a group of patients around 50. Their ACL had ruptured. Okay.
hmm
They confirmed that arthroscopically. They probed the ligament. It was ruptured.
hmm
They then stitched them back up, put them into a weight-bearing brace,
hmm
which actually did a reverse Lockman. So it kind of did the reverse action,
hmm
pulling the shin backwards. So it was kind
Yeah.
of lining up the ACL.
hmm
They then went back in at 3 months and did a repeat arthroscopy. They showed the majority of ACLs had healed. In fact, not only had the majority of ACLs healed, the majority of meniscus tears that were present in the affected knees had healed.
And this is 3 decades ago.
This is 30 years ago. It's not like this research, this idea that ACL tears can
There's a deep
heal.
and long evidence base for the protocols that we're talking about right now.
Yeah. So it's probably, I think what makes this time in history quite exciting, Sam, is that, and for patients, is they can access this information
Hmm
like that now. And
Yeah.
so I think why that group has taken off
Mm.
and why we think BLEX is probably more practical
hmm
is the patients can very quickly access the information that they can heal. We
Yes.
can get them into a program that they can do at their own home. It's
hmm
very safe. It's low risk. They can enact it in their own jurisdiction. They can do a lot of it via telehealth. And then we're finding that the healing rates are high. The healing rates are high.
Are they
And
as
so,
high? Like, how do they compare to the healing rates in the like? That's the golden question. People want to pick one protocol or the other.
yeah. Well, this is where we're not really comparing apples to oranges
Mm.
because the cross protocol has a very specific inclusion criteria.
hmm
And then the other
Has to be a
criticism of
certain type of tear.
it has to be a certain type of tear.
Yeah.
And then there's that, but then also the criticism is that they don't have a comparison arm. So
Mm.
whenever we're doing healthcare research,
hmm
for example, if we think a certain type of exercise works for back pain,
Mm.
and we just have one group of patients who just get that exercise
hmm
and they get better.
You don't know if it's time alone, the natural history
We don't
of
know if it's time alone. We
yeah,
don't know if it's the actual exercise. We don't know if it's the type of patient.
placebo.
So we don't know if it's placebo.
Yeah.
So anytime a, an intervention is being brought into the market
Mm.
or being brought into the scientific realm,
Mm.
you have to have a comparison arm, or we
Mm.
we can't know causation of
hmm
that particular treatment.
Mm.
And so the largest criticism, and which still stands, is we don't actually know what the cross protocol is doing because they don't have a comparison. Now,
Right.
I commend the authors for doing it because
Mm.
it's the largest um, healing protocol that's been undertaken.
And if it weren't for the
I,
cross brace protocol, I
yeah,
wouldn't have taken the dive into natural recovery of ACL at the time that I
yeah,
did. It's really
that
got the
which is good.
conversation.
I think you're right.
Sped up the
Like
conversation.
I think it's sped up the conversation. The challenge then though is has that become a runaway train? Because we have to go as scientists. Well, if we're being honest, we have to have a pair matched group
Hmm
against Blex or against non-Blexed.
hmm
So even nothing, like just
Yep.
doing nothing
Yep.
versus doing an exercise treatment. So if you're just doing like rehab.
Yes.
And I think in the future we will work that out and we
Mm.
can actually be then very confident with the treatments that we're offering patients. But
Mm.
we do have to be careful to go, well, I saw this heal, therefore it was this treatment because
Yeah.
yes, and we're all guilty of it, even with Blex, that we can
Mm.
say that it's the treatment that's working, but until
Mm.
we have larger studies where you're comparing, it's hard to know.
Well, and this is this is why it is such an exciting time to be a physiotherapist and to be a person undergoing physiotherapy is that there is so much data available and we can analyze it so much faster and we can debate so much quickly. I mean, we're literally on opposite sides of the world right now and we're able to discuss historical studies, but then also what's happening in modern practice. And that is just
Yeah,
what a time to be alive, right?
it's
And
cool.
it's really cool. And the whole point of World's Best Physio is not to say it's Kieran or it's Sam. I will be asking you those questions in a moment. I want to know your honest opinion on who the world's best physio is. But my expectation is that with the emerging synergies of the internet and smart devices and AI and huge data sets, that it's entirely possible that every human on this planet and on the next planet can have access to world-class physiotherapy at near zero cost. To me,
Okay,
that seems entirely possible that
okay,
someone could chat to their AI chatbot, maybe not today, but in the foreseeable future, that someone could chat to the internet and say, I've just done my ACL, for example. What do I do next? And that the response is going to be a series of questions, a series of assessments, but then a series of recommendations that I reckon would outcompete the average physiotherapist.
okay.
And and look, just to scare any physiotherapist out there who's getting a little bit complacent or thinking that they can just be an average physio, the word computer used to be a job title only last century, not that long ago. It used to be a job title, now it's a technology. I believe it's entirely possible that the word physiotherapist, in the way it's a job title now, could become a technology. And so, with that, feel free to take the conversation in any direction that you want, Kieran. Um, is that possible? Is it a good idea?
I
And
think anything's possible. I think anything's possible. It's just whether it's good or not.
mm,
And then how do we define good?
hmm
Um, I think one thing that's probably been very apparent to me as I've looked into these topics, but also zoomed out. Like I love the scientific data. I
mm,
think that's super interesting.
mm,
I love the advent of AI, and I think it has a very it has it's a powerful tool and has the
mm,
potential to be even more powerful tool. I think one thing that a lot of physios may be naive to is the effect of industry. So, like
mm,
the pharmaceutical industry,
hmm
the imaging industry,
hmm
the surgical device industry.
yeah.
So,
And something
as
you
good
mentioned
as
before about, the more advanced a solution is, the more appealing it is. If it's expensive and there's a
yeah,
machine that goes bing and yeah, it's a scarce commodity, well then it must be better, right?
yeah, that's how the perception is.
Mm,
Yeah, often. And so there's like I think there's factors at play and sort of groups of people and societies, but also industries
mm,
that would be committed to not stopping. So
mm,
as good as natural healing is, and as
mm,
good as telehealth is,
mm,
I think a lot of these privatized hospital sectors aren't really interested
hmm
in doing less surgery
hmm
because that affects their bottom line.
hmm
And so I think physiotherapists, if they start innovating and once they start looking into where they sit in the grand scheme of things,
mm,
I think so something that is exciting about BLEX is that not only is it not necessarily competitive, it's disruptive, but it's a separate entity. It doesn't
hmm
have to fall under that entity. We can still work alongside surgeons, the patients who need surgery,
hmm
and work with patients if they're seeing a physio face to face. But
mm,
we like it because we think it's disruptive
hmm
and it's kind of avoids a lot of the combat directly with industry. That's something that I find interesting.
Oh,
Yeah.
well, it's very, very uh, thought-provoking point you've put forward. You know, what role do physiotherapists have in combating the influences of big industry?
Yeah.
Because they're very, very real, and they are going to shift people's opinions. Yeah, I mean, I even think the entertainment industry, insofar as it includes elite sport. You know, if you hear
Yep.
of an elite athlete, there's an NBA player, for example, who successfully played quite several games and ended up retiring without ACLs in either knee.
Mm.
He never knew. Yeah, he injured them, way back then, and never had a repeat MRI. And then when he did eventually have a repeat MRI, he realized that he didn't have them. And there's also been some AFL players as well, Australian rules football, that have returned to a very dynamic, multi-directional sport. And I believe this industry can either reinforce that, oh, surgery and MRIs are needed because we hear on the sports page of the paper that the player's gone through that very expensive process. But it can also go the other way. It can also help the natural cause, by actually demonstrating that, wow, someone's achieved the highest of physical endeavors naturally. And yeah, before I get too carried away, I'll just mention this one last point, and then I'll hand the ball back to you, which is that the key advantage of these protocols, or any approach that avoids surgery, is the self-efficacy, the self-belief that the person develops, and the faith that they can then have in their own body's ability to heal itself. And
Mm.
the effect that that has on their outlook on life, on their ability to handle unexpected uh, challenges that are going to arise at some point in the future, that's huge. And
Mm.
and I don't think we should ever be telling people that they need something outside of their own skin to get better. That they have, and I know it's very cliche in a sense, that it was inside you all along. But I generally believe that we need to boost people's confidence and boost their faith in their own body, and avoiding surgery is one of the best ways that we can do that.
Yeah. Yeah, I think with a lot of the surgical versus non-surgical decision making, obviously it's because these industries have been set up that the patients are on the pathway,
Mm,
even even whether we like it or not.
mm,
And so um and this is where this idea of iatrogenesis comes in,
mhm,
is that how much of the current existing pathways are actually perpetuating the problems.
mhm,
And so, as someone who does this every day, I think uh, absolutely a lot of the problems that I'm encountering, especially if they've already engaged multiple people within that industry,
mm,
it gets harder to turn the patients around or to get them to trust their own body or to get them to wait and
mm,
just not rush.
mm,
Like that gets a lot harder. And
mm,
it's I think probably a lot of what I've learned is different strategies that you can use to get patients to think twice, get patients to just hold their horses. Like I had a case today where it was actually a friend's wife, and even though they know a lot about what I do, I'd
mm,
sent them my lecture. They'd already started the process.
mhm,
They'd had a surgical opinion. They were quite concerned. They were sort of contemplating early surgery.
mm,
And so a lot of those ideas, like it's it's very hard once the patients engage in that system, which most of us do by
mm,
default. So it's
mm,
like it is great what we offer, but I think sometimes when physios are assuming that the evidence is what's going to convince the patient,
mm,
or it's I think that's a tiny portion of it. And a lot of the times we have to use non-clinical ideas or communication strategies. And I think that's why that group is so
mhm.
um, persuasive for patients because
Yeah.
it's a evidence-based
And for physios.
uh and for physios even. This is the thing. Yeah. So it's not just for patients, but as I said at the start, so like I'm going to like next weekend and the weekend after for the Australian Physio Association, I'm running workshops on ACL and meniscus non-surgical management.
Mm,
And yes, we discuss the data in detail, but it's how that data is presented and then how the
mm,
physios carry themselves. And yeah, it sounds great, like as such a cool idea, like you can get this ACL to heal, but I think there's threats there's larger threats than a lot of physios realize
mm,
and it's not as easy as just telling the patients that it's
mm.
there's a lot you have to consider and be experienced in. Yeah.
Well, and look, yeah, I did rave about specialization at the start of our conversation, but so it seems appropriate to rave about it once again as we close you know close into the last few minutes. I believe that the title of specialist physiotherapist and the
Yeah.
fact that you can put a doctor in front of your name
Yeah.
is a key part of actually beating on the drum that says we know what we're talking about and
Mm.
we can help people, and in fact
Yeah.
we can help people more than the ones that are cutting them open. And, yeah, my sister's a doctor,
Uh,
so I'm a little bit I get a little bit competitive when we're comparing physio and doctors. They both do great work, but they can both fall prey to subpar practices if held unchecked, if not held in check.
yeah. Yeah. So look, I think there is an emerging greater role for expert physiotherapists around the world. I think there's
Mm,
never been a greater need.
mm,
And we're lucky in Australia because we have some of the best physiotherapists in the world. And
mm,
we do have probably one of, if not the best established postgraduate and postgraduate training programs.
mm,
And so and also, there's like just the way the Australians are. Like Australians, even though I'm from New Zealand, I know that the Aussies have kind of got this. I wouldn't say anti-authority, but they're just
mm.
kind of like question
Especially the West
existing
Australians.
systems. Yeah. So like we just don't take something on face value. Like
Mm,
just because a politician says X, Y, Z, we
mm,
don't just take that as like, okay, yeah, sure. We just go, well, why? Like, so
mm,
we're happy to question stuff respectfully.
mhm,
And so I think that that does feed into a lot of how
mm, mm,
physiotherapists, but the specialist physiotherapists, especially because the training program is a lot about questioning your own thinking,
mm, mm,
questioning experts, seeing what can we add to the existing healthcare system, or what new frontiers can we build? And I
mm,
think that's how a lot of the specialist physios
mm.
think. Yeah.
Well, and I love that they do it with such humility too. And I applied for the specialization training program, and the email is to come out today. So my
Okay.
fingers
Let me
and
know.
toes are. Oh, I certainly will. Well, as we're getting even closer to wrapping up, Kieran, I need to ask you: are you the world's best physio?
Am I the world's best physio?
Yes.
That's the most ridiculous question I've ever heard in my life.
Well, the second question is equally ridiculous. If you're not, who is? And
Look,
you could just list off some people that you are inspired by, or the
yeah,
shoulders of giants that we stand upon.
yeah. Look, I think a lot of people will refer to me as a world expert in ACL and meniscus non-surgical tear management.
Hmm.
That's probably because pound for pound, I've probably overseen the most non-surgical cases in the world.
How many you reckon you've seen?
Thousands, thousands.
Thousands of
So
non-surgical
thousands and
ACL
thousands.
recoveries.
Yes, yes. So I would say in that field, I'd be up there for that particular condition.
Hmm.
But I think probably I'm not satisfied with just ACL and meniscus. I think there's more that we're not even scratching the surface.
Yeah.
So I think, but and I also don't want to be just build my own empire. Like I want to
Mm,
see other physios grow and take their place
mm,
and start to lead patients and lead the profession as well.
mm,
Um, so I don't think I'm the best physio in the world, but I think in my niche, I think I have a lot of value to add to the
mm,
conversation.
mm.
Um, I think, did you say who do I look up to? What makes a great physio?
Who do you look up to? Yes, you've mentioned your niche. Maybe there's some other physios in
Yeah,
different
yeah,
niches that you have a
yeah,
respect for or a healthy
yeah,
competition with.
yeah. So like I was very fortunate. Like I've been very, very fortunate to be mentored by some of the best physios in the world.
Mm.
Okay. And it actually
The
started
fact
as a
that you
new
say that
graduate.
means that you have a criteria for what it means to be some of the best physios in the world.
Sure. So I had my first boss. So I worked in a private hospital with a public contract. So
Hmm.
I was seeing a lot of this elective surgery
Yep.
pretty early on, right?
Yep.
And the thing I loved about my first boss is she backed me to the hilt.
Mm.
No matter what I did. I
Mm.
think we even had a complaint one time about not giving the right crutches to a patient or something. And
Yeah.
she just backed me in.
Yeah.
So she believed in me,
Yeah.
right? And also she herself, she was quite diminutive in stature.
Mm.
And she like stood up to a lot of these board members of the hospital
Mm.
advocating for the value of physio and
Mm.
even against uh like some of the consultants where there's like been a traditional history of
Yeah. Yeah.
some of the medical, it can be a bit toxic,
She's
right?
standing up against the industry.
She was like that.
Yeah.
So I had a mentor like that early,
Mm.
and then I had a clinical mentor who was exactly the same. So
Mm.
she would say to me, like I remember working in ICU, and she called the consultant and she says, "You haven't intubated this patient correctly," and she
Mm.
just said that to the. She didn't care, so
Mm.
she would just call it out.
Mm.
So I think that not in a disrespectful way, but she was like,
Just a
"Look,
matter
this
of fact.
patient." Yeah.
Mm.
And so like that I guess those seeds were sown in me. But
Mm.
then I guess that whole since then I've just had uh private practice bosses, but also clinical mentors who have helped me to see a counter perspective, but
Mm.
also really believe in the profession.
Mm.
Like that's the one thing I struggle with online. Like I see some physios and they'll have like a clip of a physio talking or an allied health or
Mm.
even a medical doctor talking.
Yeah.
And then they'll do a green screen where they're just shredding that particular person. And it's funny.
I
And
actually
but
haven't
it's
seen
like,
any of that, but I'm told it's
well, it
out there.
happens a lot. It
Yeah.
happens a lot on Instagram, TikTok, this kind of thing. But it's like, well, if we just do that, if that's all we do, then we're never really going to go anywhere because we're just going to
Mm.
keep criticizing what we do.
Mm.
So
Mm.
I probably have a very hope-filled but realistic take on how physiotherapy can help people, what its limits are. But I think we sort of we have to both train up the physios,
Mhm.
like make them excellent,
Mhm.
communicate that to other professionals, but then we also have to communicate that to the general public without getting too caught up and just being too perfect,
Yeah.
which I
Yeah.
think
Yeah.
some of the online physio I struggle with because they're just it's like they think that the physiotherapy is just a rubbish profession, but
Mm.
I don't see it that way. So,
No.
yeah.
Well, that's a wonderfully optimistic note to finish on, Kieran. So thank you very much for the conversation today.
Lovely to meet you, Sam.